Hello, everyone. If you're an ICU nurse, you know exactly what I'm talking about. Enteral feeding can sometimes feel like we're just guessing, right? Are we starting too soon? Are we waiting too long? Are we just doing things because, well, that's how we've always done them? Today, we're going to fix that. We are going to dive deep into the latest evidence to bring some real clarity to this crucial part of our work and hopefully get you ready to lead the charge on your unit.
And, this is really where it gets exciting. The world of critical care nutrition isn't just changing a little bit, it is evolving at a fantastic pace. And this is all being driven by these huge international studies that are really challenging everything we thought we knew. So this is the big question I want you to hold in your mind today. As we go through these new guidelines, just think, are the things we do at the bedside, our daily habits, our unit protocols, are they truly in line with the best evidence? Or are we, maybe, just running on autopilot? Okay, so to build a solid practice, we have to start with the most basic question of all. Why do we feed the gut in the first place? And the principle, which is backed by every single major guideline, is actually very simple. If you don't use it, you lose it. I want you to think of the gut as a kind of factory. Enteral nutrition, or EN, is what keeps that factory running. It maintains the gut wall, it preserves that really important barrier against bacteria, and it helps the immune system do its job. Now, parenteral nutrition, PN, that's our emergency backup. It's like airlifting in supplies when all the roads are closed. It can be life-saving for sure, but it comes at a very high price, a much greater risk of bloodstream infections, liver problems, and just throwing the body's entire metabolism into chaos. That's why we always want to get that factory back online as soon as we safely can. So, if we all agree that the gut is the way to go, the very next question has to be when. And believe me, when we talk about enteral feeding, the clock starts ticking the second that patient is admitted to the ICU. The timing of that very first feed can make a massive difference in their recovery. And there it is. The answer really is that clear and simple. The international consensus from all the big players, we're talking Aspen, SCCM, is to start enteral nutrition within 24 to 48 hours of ICU admission. And look, this isn't just a suggestion, it's a core recommendation that's directly linked to better patient outcomes. But, and this is so important, there is one golden rule that you can never, ever break. We only start feeding once the patient is hemodynamically stable. This is our #1 safety check. Because feeding an unstable gut can lead to a truly devastating complication called non-occlusive mesenteric ischemia, basically gut ischemia. This is where the blood supply to the intestines just isn't enough, and the gut tissue can actually start to die. It's a real medical emergency. So we have to see that blood pressure stabilizing and those vasopressor needs coming down before we even think about starting feeds. Okay, so what about our sickest patients, the ones on vasopressors? This is where things get a bit more nuanced. The guidance here is what I would call cautious optimism. In a state of controlled shock, so the pressors are running, but they're stable or even weaning down, we can actually begin some low-dose or trickle feeds. The absolute key here, though, is vigilant monitoring for any sign of intolerance. And if that patient becomes unstable or needs active resuscitation for any reason, you hold the feeds. Immediately. No questions asked. So now that we've figured out the why and the when, let's tackle the next big question. How much should we be feeding our patients? And this is an area where we're seeing a really big shift away from those one-size-fits-all calculations and toward a much more personalized BMI-based approach. Just take a look at this chart for a moment. It's a really powerful tool you can use right at the bedside. Now, I want you to notice the caloric goal column. See how for our overweight and obese patients, we're actually aiming for fewer calories per kilogram. Why is that? Well, it's because we want to fuel their lean body mass, not overfeed their fat tissue. But now, have a look at the protein goal column. See how that number stays high and even goes up for our larger patients? This is an absolutely crucial distinction. And this just brilliantly illustrates the modern strategy. The approach is called permissive underfeeding, and honestly, it's a game changer. By deliberately giving fewer calories in that first week, we lower the risk of hyperglycemia, which can mess with the immune system, and we also lower CO2 production, which can make it harder to wean patients off the ventilator. But, and this is the key takeaway, we never compromise on protein. Protein is the building block for healing, for fighting off that awful muscle wasting we see in the ICU. So the new mantra is simple: high protein, restricted early calories. All right, I want you to get ready for this next one. We are about to tackle what is, without a doubt, the single biggest, most impactful change in daily ICU nursing practice when it comes to enteral feeding. We're talking about abandoning a ritual that has been drilled into us for decades. This quote from the literature, it's a real bombshell. It represents a complete 180 from what many of us were taught. The evidence is now just so strong, so overwhelming, that international guideline committees are putting out their strongest possible recommendations against a practice that has been a cornerstone of our care for generations.
So let's just make this as clear as humanly possible. The new standard of care is to stop the routine, scheduled monitoring of gastric residual volumes. It is an outdated practice, it's not based on good evidence, and it's time to take it out of our protocols. Full stop.
So why this huge shift? Well, it's because the evidence is just undeniable. First of all, GRV is wildly unreliable. The number you get can be completely different based on the patient's position or even your own technique. Second, and this is the most important part, it's not protective. It does not reduce the risk of aspiration or pneumonia. And finally, it's just plain counterproductive. Think of all the unnecessary interruptions in feeding it causes, which means our patients are consistently underfed and just not reaching their nutritional goals.
So if we stop chasing this one meaningless number, what do we do instead? Well, we become better clinicians. We shift our focus to a real, holistic physical assessment. Is the abdomen getting distended? Are we keeping an eye on bowel movements? Is the patient showing any signs of discomfort? These clinical signs are so much more valuable than any number you can pull back from a syringe.
Now, as we get better and, more aggressive with our feeding, we also have to become more vigilant about a potentially fatal complication, refeeding syndrome. This is a critical safety topic that every single one of us needs to have completely mastered. This slide gives us a really clear 5-step action plan to keep our patients safe. Step 1, and this is a big mental shift, assume every critically ill patient is at risk. Step 2, we have to be vigilant with our monitoring. That means daily phosphate levels for at least the first week. Step 3, if you see that phosphate level drop by more than 30% or fall below 0.65, you hit the brakes. Restrict calories immediately to about 500 per day for 48 hours. Step 4, at the same time, aggressively replace electrolytes, and not just phosphate, but magnesium and potassium too. And finally, step 5, give high-dose thiamine, which is essential for carbohydrate metabolism and prevents some really severe complications. Following these 5 steps can literally save a life. We have covered a huge amount of ground here, haven't we? Moving from the basic principles all the way to these major practice-changing shifts. So let's bring it all together and talk about your role right there at the bedside in championing this new, better standard of care on your unit.
This right here is your checklist for change. These are the key evidence-based takeaways we can all start putting into practice tomorrow. Feed early, but only in stable patients. Prioritize the gut. Use those personalized targets that really push the protein. Abandon routine GRV checks and do a great clinical assessment instead. And always, always be on the lookout for refeeding syndrome. So the takeaway here is that the science is really settled on these points. We now have clear, evidence-based, internationally accepted guidelines to help us provide the absolute best nutrition care for our patients. The only question that's left is the one you see on this slide. And it's not for me to answer. It's for you to take back to your team, to your colleagues, and your leadership. How will you make this the standard of care on your unit starting tomorrow?